Welcome to Health Insurance Options Conference Call. At this time, all participants are in a listen-only mode. I would now like to turn the call over to Nicole Jarvis. You may begin.
Hi, everyone, and thank you all for attending today. My name is Nicole Jarvis. I'm a Senior Manager of Programs at Cancer and Careers, and I'll be the host for today's 60-minute webinar. Now, really quickly before we begin, just a few housekeeping items related to accreditation. The webinar today is accredited for CEUs by ANCC, NASW, the New York State Education Department State Board for Social Work, the California Board of Registered Nursing, and the Society for Human Resources Management. If you plan on receiving continuing education credit for this program from any of these accrediting bodies, please proceed with the following steps. First, you must call in individually. Participants who listen in on someone else's line will not receive credit. And second, you must complete and submit the evaluation and post-test, as well as receive a passing grade on the post-test. Following today's session, you'll receive an email with all of this information. This email will be sent by 5 p.m. Eastern Time tomorrow, and certificates will be emailed within 4 to 6 weeks. Also, please note that the planners and presenters for this program have not disclosed any pertinent financial relationships or conflicts of interest, and that no commercial support was provided for this program. The lead sponsor for the Balancing Work and Cancer webinar series is Genentech. In addition, Cancer and Careers year-round sponsors support all of CAC's core programs, including this one. Thanks to their support, we've created the Balancing Work and Cancer webinar series to provide patients, survivors, and healthcare professionals with concise, targeted information to help you understand a variety of issues that surround balancing work and cancer. Now, as we all know, health insurance is an extremely important part of the employment conversation. Unfortunately, it can also be very confusing when trying to understand the various options and existing policies, especially in the midst of dealing with a diagnosis. I'm thrilled today to introduce our speaker, Monica Bryant, who will explain the very complex issue as clearly as possible for us all. Monica is a cancer rights attorney and the COO of Triage Cancer, which is a national nonprofit organization dedicated to providing education and resources on cancer survivorship. She's been a longtime collaborator and is extremely skilled at taking complex legal and insurance issues and making them easier to understand. So thank you so much, Monica, for being here tonight, and I'll hand it over to you.
Thank you so much. It is great to be here talking about health insurance. So in today's presentation, we're going to go over some of the consumer protections and options and how to actually go about making choices amongst those various options. And of course, we will talk about some of the potential changes to our healthcare system. Now, I have to preface this whole call with the fact that I recognize we are all waiting with bated breath to find out the results of the presidential election, and there are some potential changes happening. So what I'm going to talk about today is what exists in this country as of today. But the unfortunate reality is, just like with employment law, with health insurance law, things are frequently changing, and so we can only operate based on what we know today, but I'm also going to point you to places where you can get some information moving forward. Now, financial toxicity has certainly become the buzz term over the last couple of years, and what it refers to is the burden or the impact that cancer can have on somebody's finances. And this term was coined out of researchers from Duke, and what was interesting about their particular research is they didn't just focus on how the out-of-pocket expenses impact somebody's bank account, but they also looked at how it impacts somebody's emotional and physical health, and certainly how it can impact quality of life. So it's a relatively new term, but it's certainly not a new problem. So why is financial toxicity so hard to address? There are multiple contributing factors, and if all or at least most of those factors aren't addressed effectively, there's no way to minimize or avoid financial toxicity. And the number one contributing factor to financial toxicity is health insurance status. So that could mean, does somebody or does somebody not have health insurance? But it could also mean, does somebody have the right health insurance policy for them? So at Triage Cancer, we have a checklist to addressing financial toxicity, and I realize it's very hard to read on the screen, but I've given you the link below where you can go and download for free the full-size version of this checklist. And what this checklist does is it poses many of the questions that can be asked of somebody to try to start avoiding or addressing financial toxicity. And on the full-size version that you'll find at this link, not only will you see these questions in an actually readable font, but on the right-hand side, you'll also see all the resources that we have at Triage Cancer to help you address those questions. But specifically when we're talking about health insurance, one of the things that we know is that many people in this country don't understand how health insurance works or even what their policies provide them. So there's tons of studies, but this particular study out of Policy Genius that they do every year shows that only 4% of Americans could correctly identify the most frequently used terms in health insurance. So if you are joining us today thinking, I don't have a clue about health insurance, rest easy in that you're not alone. But we also want to address that and increase that number. So I'm going to start with the basics. When we talk about the costs to have health insurance, there are several different terms that we use. So just to have health insurance, you're going to pay your monthly premium. And you're going to pay that whether you use healthcare or not, whether you go to the doctor or not. So it's very similar to having homeowners insurance and never filing a claim. But then there are some costs that you're going to incur when you actually use your healthcare. Your deductible is a fixed dollar amount. It's going to depend on your policy. So some plans have a $500 deductible, some have a $5,000 deductible. But you have to pay this deductible out of pocket before your insurance company starts picking up their share of the cost. Their share of the cost is referred to as cost share or co-insurance because you're literally sharing the cost. So if you have a plan with an 80-20 co-insurance, that means that once you've met your deductible for the year, your insurance company is going to start picking up 80% of your healthcare costs, and you're responsible for 20%. Now, many plans also have an additional payment called a copayment, and you're going to pay this each time you get care. So it's very common for plans to have a $25 copayment when you see a doctor, or a $250 copayment when you go to the emergency room. Now, one of the most important things I believe everybody should know about their policy is the out-of-pocket maximum, because the out-of-pocket maximum is, in theory, the most you're going to pay out of pocket for your health care in a worst-case scenario. And the way that we get to our out-of-pocket maximum is by adding up everything we pay out for our deductibles, everything we pay out for our co-insurance, and everything we pay out for the copayment. So it's everything we pay out of pocket except those monthly premiums. Now, the devil is definitely in the details. So typically, only payments made towards in-network providers are going to be considered in an out-of-pocket maximum. And if you have a plan through your employer, those employers can sometimes have a different formula to getting to that out-of-pocket maximum. So, for example, sometimes they carve out the deductible. So if you have an employer plan, it is important to look at how they come up with the out-of-pocket maximum. So here's an example of how this all works. Let's say you have a plan with a copayment for the ER of $250, a $2,000 deductible, it's an 80-20 co-insurance, and you have an $8,000 out-of-pocket maximum. So if you haven't used any health care for the year, but you get into an accident and spend the week in the hospital, and you walk out with a $102,000 hospital bill, what do you actually have to pay? So you always pay that copayment. So you've paid the $250. Now you have to meet your deductible. So in order to do that, you have to pay another $1,750, and that gets you to that $2,000 deductible. But you have a co-insurance of 20%. Well, 20% of $100,000 is $20,000. But fortunately, you have a plan with an $8,000 out-of-pocket maximum. So since you've already paid $2,000 in your deductible, you only have to pay another $6,000 to get to that $8,000 mark. And at that point, the insurance company is responsible for paying the rest of that bill. Now, I am not suggesting that $8,000 isn't a lot of money. Of course it is. But when we look at the alternatives of what we would pay without the out-of-pocket maximum, so $102,000, or, $20,000, or what we would pay with no insurance, which would be $102,000, $8,000 starts to sound a little bit more reasonable. Now, if you would like to hear any of that again, or you think there are people in your life that would benefit from hearing those terms and that example, all of that is included in one of our animated videos on health insurance basics, and it's available in English and Spanish and has Tagalog subtitles, so you can check that out on our website. Now, there are also some terms that are important to understand about prescription drugs. So most plans that provide prescription drug coverage have a formulary, which is just another name for the list of drugs that they're going to cover and at what rate. Most formularies are broken into different tiers, and the tiers are going to define how much the insurance company is going to pay for drugs in that particular tier. So this is a common breakdown of formulary tiers, but every plan's a little bit different. But what's valuable to know about this is if you are prescribed a formulary generic drug, those are typically drugs that are going to be covered at the highest rate. And those could just have a nominal dollar copayment. So like a $5 copayment to get a formulary generic. As compared with a specialty drug, which often have a co-insurance, which means now you're paying a percentage of the cost of that drug. And unfortunately, many cancer drugs fall into that category. It's also very valuable to understand about your plan how they treat prescription drugs. So is there a separate drug deductible? Is there a separate out-of-pocket maximum for prescription drugs? Because understanding that information is going to be key in making sure that A, you've picked the right plan, and B, you are maximizing your plan to the extent possible. Now, there are 3 places in this country where we get health insurance. So the largest number of Americans get their insurance through an employer. The second largest group of Americans get their insurance through the government. So primarily that's Medicaid and Medicare, but it also includes veterans or military plans and high-risk pools. And then the smallest number of Americans go directly to a health insurance company to buy their health insurance. So given the fact that the largest number of Americans get their insurance through an employer, what happens if somebody has to leave their job due to a cancer diagnosis? COBRA is the federal law that allows eligible employees to keep their employer-sponsored health insurance when they would normally lose it. So it's the exact same policy, which means that if you are in the middle of the year and you've already met your deductible and your out-of-pocket maximum, that continues to be true for you. It has the same network, the same providers, the same prescription drug coverage. So those are all the benefits. The downside is that it can be expensive because now the employee is responsible for up to 100% of the premiums plus sometimes a 2% administrative fee. So it can be very shocking to see what those monthly premiums are on a COBRA plan. The amount of time you get to keep COBRA depends on your qualifying event. So if the qualifying event is that you lost your job, or even if your hours have been reduced, so let's say you've gone from full-time to part-time and your employer doesn't provide benefits to part-time employees, that would be a qualifying event, and you would be eligible to elect COBRA for up to 18 months. Let's say instead the qualifying event is that you're aging out of your parents' policy. That would give you COBRA coverage for up to 36 months. And even though we call it COBRA coverage, it's very important to remember that COBRA isn't actually a plan. It's just the law that provides you with the benefit of keeping your employer plan. Now, there are two times when COBRA might last longer than that 18-month period, and that's if somebody is deemed to be disabled by the Social Security Administration within the first 60 days of electing COBRA. Then they get an 11-month extension, so they would get a total of 29 months of COBRA coverage. And that's designed to bridge the gap for somebody to then be eligible for Medicare. The other time is when there's a second qualifying event. So let's say that a child is on a parent's plan, the parent leaves their job, so that triggers the 18 months of COBRA, but then during that 18 months, the child also ages out of the parent's policy. That would be a second qualifying event and would give that child, quote unquote, up to 36 months. I realize calling a 26-year-old a child is strange. There are also a handful of times when COBRA might end early, and two that I want to point out specifically important right now are if the employer stops offering a health plan to all the employees, or if the employer goes out of business, then COBRA ends. And the rationale for that is that it's the exact same plan that the employer is offering. So if the employer stops offering the plan or the employer doesn't exist anymore, there's no plan left for you to keep. And I say they're particularly important right now is because we're seeing, unfortunately, lots of businesses have to cut benefits or even go under due to the pandemic. So that might be something, for the healthcare professionals on the line, that might be something that you're seeing patients have to contend with, that they expected to have COBRA longer. Now, the federal COBRA law is only available to people who work for employers with 20 or more employees. But for people who work for smaller employers, they might have similar benefits, but it would be under the state COBRA statute. And the details definitely vary state to state, but they're going to cover those smaller employers under 20. And if you want to look at the specifics about your state, if you go to our chart of state laws, and I've given you the link here, you can click on your state and it will give you specifics about the law in your state. So between 2000 and 2010, there were significant efforts to reform the healthcare system. And there were a couple of reasons why that became so necessary specifically in that time period. And the first was there were increasing amounts of confusion about health insurance options and how health insurance worked. For example, we put health insurance into Google and it came back with 1 billion hits. And I'm pretty sure that might be the max that Google will ever return to you. So here is the tool that we use to answer all the questions that we have, and 1 billion hits is not actually helpful. So it just goes to show you that it's confusing. We also know that for individuals who had pre-existing conditions, it was very challenging to obtain health insurance that was quality and affordable. And pre-existing conditions really ran the gamut from cancer to severe acne. It will certainly most likely include COVID moving forward. So it can really be all sorts of things. And then certainly in that 10-year period, we continue to see the cost of health insurance go up, but the quality go down. So it really just spoke to a need for reform. And what we ended up with in 2010 was the Patient Protection and Affordable Care Act. It was signed into law on March 23rd, 2010. It's also referred to as Obamacare, but really that's a misnomer because it's a compilation of multiple pieces of legislation from multiple members of Congress that kind of were all put together in a single package. Now, the ACA is a huge piece of legislation, and it touches almost every aspect of our healthcare system, and I can't possibly talk about all the things in an hour. So I'm going to focus in on the consumer benefits it provided to us, and when I say us, I mean all of us, because we are all consumers of healthcare, and the new health insurance options. So the ACA really tried to address that quality piece that I was talking about. So some of the consumer protections that we think are most valuable to the cancer community are the fact that insurance companies can no longer cancel your policy just because you get sick. And that happened all the time. There also can no longer be lifetime or annual limits on a policy. So prior to the ACA, many health insurance policies had annual limits that could be as little as $50,000 and lifetime limits as little as $1 million. And again, I realize that sounds obscene to say that it's as little as $1 million, but when we talk about the cost of cancer care, that's incredibly easy to reach. And then at that point, that insurance company is just not going to cover anything else for that person. So under the ACA, no more lifetime and annual limits on essential health benefits. The ACA also made federal law the fact that young adults can stay on their parents' plan up until the age of 26. And it made sure that insurance companies were still responsible for the routine costs of care. In other words, the costs they would pay no matter what, even if somebody enters a clinical trial. And that's incredibly valuable when we think about how important clinical trials are to the cancer community. Now, this was existing law in many states already. The ACA just made it law in all 50 states. The ACA also brought to the forefront the importance of preventative services. But what we also know is that many people were foregoing getting their preventative services because they had high deductibles or copayments. So the ACA said most plans have to cover certain preventative services for free. And what free means is they can't charge a copay, they can't charge a coinsurance, and they cannot charge a deductible. So we're talking about immunizations and blood pressure medicine and many cancer screenings. These are just a few examples. And if you go to healthcare.gov, you can see the entire list. And then I did a whole host of other things like make sure that most plans had a certain level of coverage, that they had to spend a certain amount of all of the money they bring in on healthcare, so not the bonuses to execs, and all sorts of things like that. And then the ACA also, sorry, I'm having a technical issue over here. The ACA also made sure that we had some protections when health insurance companies said no. So many people going through a cancer experience end up with a claim denial. And now we have the right in every state to engage in two levels of appeal. So the first level is an internal appeal where you essentially go back to the health insurance company and you say, please reconsider. But then there's another level called the external appeal or independent medical review, called different things in different states. And this is where you go to an independent entity and ask them to reconsider or ask them to look at your case and decide whether or not the insurance company should have paid. So again, this existed in some states already, but the ACA made it national law. Appeals are incredibly important when we talk about how to avoid financial toxicity. We know that around 50% of all claims that are appealed get decided in favor of the patient. So 50% of the time when the insurance company is saying, nope, we're not paying that, they're wrong. But we also know that less than 0.5% of all denied claims are ever appealed. So millions of claims are denied and never get appealed. Yet, theoretically, about 50% of those could be decided wrong. So we really stand on this soapbox for a minute because we want people to know that if they get a claim denial, there are steps that they can take. And then finally, if the ACA did nothing else with respect to consumer protections, but these two things, it still would have been game-changing. So the ACA says that insurance company can only look at 4 things when they're deciding what they're going to charge someone for their premium. So are you buying an individual plan or a family plan? The more people you put on, the more expensive it's going to be. Your geographic location, so that's based on zip code. Your age, so yes, the older you get, the more you can be charged, but there's now a cap on how much more you can be charged, which is significant. And then in many states, if you use tobacco, you can be charged more. So what you don't see in this list is pre-existing conditions. They can't charge you more for being sick or your health status. Also, gender. Prior to the ACA, women were charged more for the same health insurance policy that a man was getting. So in addition to limiting what they can look at to decide how much they're going to charge you, the ACA went one step further and said that insurance companies can also not consider pre-existing conditions to decide if they're going to sell somebody a policy or if they're going to cover a particular service. So I've been doing this over a decade now. I never thought that this was going to come to fruition. The law was signed in 2010, but this didn't take effect until 2014, and we were sure that something was going to happen between 10 and 14, but it didn't, and it really changed the way that we look at health insurance. But here's the problem. There have been multiple efforts to repeal the Affordable Care Act, most significantly in the last 3 years. And in all of that, all of the elected officials have said, oh, but we like those pre-existing condition piece. We want to keep that protection. The problem is they're only talking about number 2. They're not talking about number 1. And if you only keep number 2 without number 1, and insurance companies can now charge me whatever they want because of a cancer diagnosis, it's not actually a protection to me to say, oh, but you have the right to buy it. So in our opinion, in order to truly remain a protection for the cancer community, these 2 pieces have to stay coupled. So in addition to providing new consumer protections, the ACA also provided some new health insurance options. Prior to 2014, the only way to access Medicaid was to have a low income and a low asset level. And so assets are things like retirement accounts or savings accounts, and be able to walk through one of these 4 doors. For most people in the cancer community, they were walking through the age, blind, and disabled door, which is a terrible name for a program, but that's how they got access. But that definition of disability was it was the Social Security Administration's definition is incredibly high. So there were several barriers to getting access to Medicaid. So the ACA created a 5th door, and this door is just based on income. And it's for people who have incomes at or below 138% of the federal poverty level, which for this year is $17,609. So there's no resource test. There's no requirement to meet a certain level of disability. It's just income. Now, those 4 original doors still exist with the resource and asset test and being able to walk through one of those doors. This is just in addition. When the ACA was passed, this 5th door was supposed to exist in every state. But in 2012, the Supreme Court got their hands on the ACA and muddied the waters a bit and essentially made it voluntary for states to expand. And this is where we are as of right now. Now, this chart changes all the time. You can see all these footnotes. So these are all the states that came on after the initial expansion period or have moved back and forth. And that happens as there's new governors and legislatures that are passed. You can see the 2 in red. Those are voter propositions that were approved this year, but they're not supposed to start until 2021. So you can see quite a bit of flux. Now, the states on the right represent approximately 3 to 5 million people that would have had access to Medicaid and health care had their states expanded. Now, we get asked a lot, well, why do I care about Medicaid? I have employer-sponsored insurance, so why do I care if my state expands or not? Well, there's a couple of different reasons. So there's the humanitarian reason, in that Medicaid is responsible for providing access to health care for some of our most vulnerable populations, so seniors, children, people with disabilities. Certainly, we are seeing more and more people fall into the category of having jobs, but that don't offer health insurance. But then we also know that in the states that have expanded Medicaid, health insurance premiums have gone down for everybody. We also know that in states that have not expanded, uncompensated care rates for hospitals have gone up. So that's when hospitals provide care, but they don't get reimbursed for it or paid for it. And hospitals have to survive financially as well. And what we see happening is emergency rooms get closed or whole hospitals get closed. So even if you have the best health insurance available to you, if you're in an emergency and that local ER is closed, that impacts you. So really, we often talk about these policy issues in a vacuum, but the reality is they're more like dominoes. And when we start picking out one or two dominoes, we kind of lose the whole piece. Now, Medicare is the federal health insurance program for individuals who are over the age of 65 or have been receiving Social Security disability insurance for 2 or more years, or have end-stage renal disease or ALS. Now, Medicare is incredibly complicated, and most people don't understand Medicare. So I'm going to do a very quick overview, but point you to some other places where you can find some additional information. So there are actually 4 different parts to Medicare. Part A is hospital insurance. And for most people who have worked and paid into the system in this country, Part A is going to be premium-free. Part B is medical insurance. So it's going to cover doctor's visits and immunizations and oftentimes IV chemotherapy. Even if you worked and paid into the system, there's a monthly premium with Medicare. So for this year, it's $144.60 for most people. Over the last couple of years, Medicare premiums have gotten tied to income. So for people who make quite a bit, their Medicare Part B premiums might be higher. There's also an annual deductible of $198. So when we talk about Part A and Part B together, it's often referred to as original Medicare because when Medicare was created, that's all that existed. Part D is for prescription drugs. Part D coverage only came to fruition in 2003. So what you see on the left-hand side is what we often refer to as Lane 1 of Medicare, Part A, Part B, Part D. But an alternative, or Lane 2, has been created in Part C, also known as Medicare Advantage plans. Now, these are managed care plans, so they're HMOs, they're PPOs. They operate a lot like what you would get through an employer, where you have a network of providers and you pay one premium and one deductible. And what you get in these Advantage plans is all of your Part A and Part B services bundled into one Advantage plan. And about 90% of all Part C plans also include prescription drugs. So in Part D, there's something referred to as a donut hole. And in order for me to explain what the ACA did to Part D coverage, I have to talk to you. We have to go back in time to before the ACA. And there's supposed to be animations here, so bear with me. And start with me on the left-hand side of this image. So prior to the ACA, this is how prescription drug coverage would start. So the patient would pay $295 of their deductible, and they would pay that out of pocket. Then they would enter the initial coverage phase, during which Medicare was responsible for paying 75% of the prescription drug cost. The patient was responsible for 25%, until the total drug costs got to $2,700. Then they entered the donut hole, where Medicare paid nothing and the patient was responsible for 100% of their prescription drug costs until the total out-of-pocket costs got to $4,350, and then they entered the catastrophic coverage phase, where Medicare pays 95% and the patient pays 5%, or a nominal dollar figure. But when we're talking about cancer care, it's almost always the 5%. So as you can see, there was this whole period of time where a patient was responsible for thousands of dollars out of pocket. And when you think about who's on Medicare, seniors and people who can't work due to a disability, that is a significant problem. So the ACA tried to improve Medicare as well. It included some of those free preventative services, just like with private insurance, but then it most significantly closed that donut hole. And it did it over time, a little bit each year. And in this year, the donut hole is completely closed. And so this is what prescription drug coverage looks like in this year. So again, starting on the left with me, the patient pays $435 of their deductible out of pocket. Then they enter the initial coverage phase, where Medicare pays 75% and they pay 25%, until their total out-of-pocket drug costs get to $6,350. Then they enter the catastrophic coverage phase, where Medicare pays 95% and they pay 5%. So as you can see now, there's coverage all the way through. Now, I mentioned that was the very quick and dirty of Medicare, but please know that if you are Medicare eligible and you're trying to figure out your choices and what is available to you, we have many resources, including an hour-long webinar I just did last month, archived on our website, and several quick guides you can print out for free. Now, in addition to the fifth door in Medicaid and some improvements to Medicare, the ACA also created a new way for us to shop for health insurance, and that's through the state health insurance marketplaces. When the law was originally passed, these were called exchanges, and no one knew what that meant, and so we rebranded. By we, I mean the global we. We rebranded them to the state health insurance marketplaces, and guess what? No one really understands those either. So the best way for me to talk about these is to imagine a health insurance shopping mall or Amazon for health insurance. What you are buying in these marketplaces are insurance plans from private health insurance companies. So the plans fall into the top of our triangle of coverage. So they're not government plans. They are private insurance plans. So people will often say, well, why, if they're private insurance plans sold by private insurance companies, why would I go through the marketplace? And the reason is there are some added benefits to shopping through the marketplace. So the first is that there cannot be an out-of-pocket maximum more than $8,150 for 2020 or $16,400 for a family. I'm sorry, I finalized these slides right before the 2021 numbers came out, so there are updated numbers on our website. I think now it's $8,550 for an individual. And again, that is a lot of money, and those are huge jumps from year to year. And I will say that in the last 4 years, we've seen significant jumps in these out-of-pocket maximums. But when you think back to my example of the $102,000 hospital bill, this starts feeling slightly more reasonable. It's all relative, right? So in addition to having that cap on out-of-pocket maximums, there may also be financial assistance. And there's two types of financial assistance. The first is a premium tax credit, which lowers the amount that you're paying out of pocket monthly. The second is a cost-sharing subsidy or a reduction, and that's going to reduce things like your deductible or your copayments. The other benefit is that things are standardized in the marketplace, and they're standardized across cost share. So there's 4 main categories. Bronze plans have a 60-40 cost share. So that means once you've met that deductible, the plan's going to cover 60% and you're going to cover 40%. Silver plans are 70-30, gold are 80-20, platinum are 90-10. Bronze plans are going to have the lowest monthly premium, but the highest out-of-pocket costs when you go to use your care. Platinum plans are going to have the highest monthly costs, but the lowest out-of-pocket costs. But what's useful about this is you can say, okay, I'm a super healthy person. I never go to the doctor. I just need insurance for the what if. Only show me the silver plans. Or conversely, I am in the midst of cancer treatment. I see a doctor every 60 seconds. Show me the platinum plans. And it's just like on Amazon. You can weed out what you're not interested in and just focus on what you're looking for. Now, the financial assistance is based on household size and income level. And unfortunately, it's complicated because it's different depending on what state you live in. If you live in a state that expanded Medicaid, if you have an income under 138% of the federal poverty level, you're eligible for Medicaid. If you have an income between 138 and 400%, you'll get a premium tax credit. Now, if you've chosen a silver plan and your income's between 138 and 250%, so those middle two columns, in addition to being eligible for a premium tax credit, you could also get that cost-sharing subsidy. Now, unfortunately, in states that didn't expand Medicaid, things are a little more complicated. So in this scenario, people who have incomes between 100% and 250% get that cost-sharing subsidy for a silver plan. But you still only get a premium tax credit if you're between 138 and 400%. And the problem there is it's the premium tax credit that gives us the ability to buy the plan. The cost-sharing subsidy is only useful once we have it. So it created an additional disparity that the ACA didn't think about because the ACA thought every state was going to have Medicaid. Now, when we're talking about financial assistance, you're projecting your income for the year coming. So if you're applying right now, you're thinking about what your 2021 income is. The good news is you can report changes mid-year. So if you are in a position where you don't have a job right now, you report that income, but then if you get a job in March, you report the change to the marketplace and they will adjust your financial assistance accordingly for the rest of the year and you won't end up owing back. So what all of this means is that now we're in a place where someone has multiple options if they experience a life-changing event and lose coverage. So if they're losing employer-sponsored coverage, they could pick up COBRA or state COBRA, which would be, remember, exactly the same plan. Lane 2 would be a new plan in the marketplace. Lane 3 would be maybe they're eligible for another group plan through a spouse or a parent's plan. They're under the age of 26. Or maybe now, due to circumstances, they are eligible for Medicaid or Medicare. The trick with this, though, is that you have to pick a lane and stay in it. You don't get to change lanes until the next open enrollment period. So if you are considering shopping in the marketplace, I default to talking about it as a website, but it does not have to just be a website. There's a toll-free hotline. There's a paper application that you can mail in. You may also be able to get help enrolling in person. Now, these entities are called marketplace assisters. The challenge is that over the last 4 years, the budgets for these organizations has been slashed by the administration, and so many of them can't afford to provide these services to Americans anymore. But if you go to healthcare.gov, contact us, you put in your zip code, and it will show you if there are any assisters in your area. I will also tell you that now, last open enrollment and this open enrollment, in addition to seeing assisters, you will also see brokers or insurance agents. Our challenge with that is that unlike assisters, brokers are not unbiased, and that's because they actually get paid by the insurance companies. So they have a vested interest in people picking particular insurance companies. So we just want people to understand that if they really want a completely unbiased opinion, they should look for a sister organization. Depending on what type of coverage you have is going to impact when you can enroll. So Medicaid applications are accepted year-round. The marketplace has an annual open enrollment period, which we are in right now. And for most states, it will go to December 15th. I say most states because states that run their own marketplaces may have longer enrollment periods. And you, again, can find that information on our chart of state laws. Medicare also has an annual open enrollment. We are in it as well. It runs from October 15th to December 7th. Marketplace plans and Medicare plans are calendar year plans, which means even if you pick a plan on day 2 of open enrollment, that plan doesn't start until January 1st. So you have to make sure you have coverage for the rest of the year. Now, employer plans vary, so you have to check with your employer, but many have a fall open enrollment to coincide with a calendar year start date. But thankfully, the ACA did address the idea that things change mid-year. So if you have a life-changing event that is going to result in you losing coverage or changes your family or where you're living, that triggers a special enrollment period with the marketplace, and you have 60 days to pick a new plan in the marketplace. So we have all these new options. How do we actually go about making choices? So I'm going to give you an example using the marketplace, but this example can be used whether you're trying to compare 2 marketplace plans, whether you're trying to compare 2 plans your employer offers you, whether you're trying to decide, do I take my employer plan or is the marketplace plan better for me, or even if you're trying to decide between 2 Medicare plans. This analysis will work. So you could go at any time during the year to healthcare.gov, see plans, and start to see what's available for you. You'd put in some basic information like your age, your gender, your household size, and your income level. And then your options pop out. So here are on the left 3 different plans that are available to this fictitious person. The top is a bronze plan with $102 monthly premium and a $7,000 out-of-pocket maximum. A silver plan with a $239 monthly premium and a $6,500 out-of-pocket maximum. And then a gold plan at the bottom with almost $400 monthly premium and a $4,000 out-of-pocket maximum. Now, if you just saw what's on the left, it would be very hard to figure out which plan would cost you the least at the end of the year, assuming you're going to hit that out-of-pocket maximum. And again, in the cancer community, we can make that assumption most years. You can't actually do it. You have to do the math. And the way that you do the math is by taking that monthly premium and multiplying it by 12 and adding the out-of-pocket maximum. And when you do that, you can see that the quote-unquote cheap bronze plan and the expensive gold plan are actually pretty comparable come end of year, but that the gold plan ends up being, $50 cheaper. What's helpful about this is we can then start to understand and plan for worst case scenarios. But it's not just about the total out-of-pocket costs at the end of the year. We also want to look at things like deductibles. So at that top plan, it's a $6,000 deductible, which means that you'd have to write a $6,000 check before it would ever start to pick up even 60% of your costs, your medical costs. Whereas the gold plan only has a $1,000 deductible. So most of us are in a position where we can pay a little bit more monthly compared with coming up with a big chunk up front. In addition to the cost, you have to make sure that your doctors and hospitals and facilities and providers are all in the plan's network. And you want to make sure that any prescription drugs you're taking are covered and that you understand how prescription drugs work in your plan. But getting health insurance is only half the battle. Once we have the health insurance, we also have to make sure that we're being savvy consumers and making the most of that plan. So using in-network providers whenever available, asking for pre-authorizations, paying attention to bills, leveraging those out-of-pocket maximums. So what I mean by that is if you've met your out-of-pocket maximum for the year, think about, is there any other care that you need? Get it in this year versus waiting until January when everything starts over. And then, of course, appealing those denials. Now, here is the challenge. The challenge is that there are lots of things that could potentially happen that could impact almost everything that I've talked about today. One of the most significant things is the fact that the Affordable Care Act is currently scheduled to be heard by the Supreme Court in 6 days. And depending on what happens with the Affordable Care Act and the election, we could be in a position where we lose many, if not all, of the protections that I've talked about today. So, of course, we're very concerned about that, and we have lots of things on our blog and on our website and on our advocacy page if you're interested in learning more and getting involved. But the moral of the story that I really want to leave people with is the Affordable Care Act is still law today, and we're getting lots of questions about if people should buy plans through the marketplace this year for 2021. And again, the ACA is still law, and so even if it was to be ruled unconstitutional next year, if you have that plan, there's certainly an argument to be made that you would get to keep that plan at least for the end of the year. So while I don't have concrete answers, that's the best sort of information that we have at the moment. So my top takeaways are you cannot be denied health insurance or charged more because of your health condition for now. Stay tuned. Many of us are in open enrollment right now, and so weigh your options carefully and make sure you do that math. If you end up with a denial of care, make sure that you appeal it, and then, of course, continue to stay updated with what's going on, and we will do our best to keep you as informed as possible. So with that, I'll turn it back over to Nicole.
Great. Thank you so much, Monica. I know that was a lot of information in a small amount of time, and I'm always really impressed by your ability to do that. I know it is a lot of information, so just so you guys know, you can download the slides from today. We sent them out earlier, and we'll also be sending them in the email that we send out tomorrow. I do just want to point out some upcoming events that we have. Obviously, we're rounding out the end of the year, so we have one more Balancing Work and Cancer webinar on a new topic, communicating effectively. So registration is still open for that if you guys are interested in checking that out. And I do want to just point out that we do have our webinars recorded, so if you're interested in checking out any that we've done so far this year, please go ahead and do so. And here's the contact information for Monica. And I'm just going to leave up the CEU requirements, and I'm going to open up the call up for questions and have our operator, Christy, explain how the Q&A works. Christy?
Thank you. The floor is now open for questions. If you would like to ask a question, please press *1 on your phone now, and you will be placed in the queue in the order received. If your question has been answered or you wish to remove yourself from the queue, please press #. We are now ready to begin.
I'll just see if we have anyone on the phone yet.
And I'm showing a question from Anna Maria Esposito from Memorial Sloan.
Yes, hi. My husband is on disability, and I'm currently not working because I have the underlying medical conditions, so I can't go to work at school, so I'm unemployed right now. His COBRA insurance will end in February. I do have the marketplace Medicaid, but primary was United Healthcare. So with this happening very soon, what do you suggest that I do? Should I call up the marketplace for open enrollment period, December?
So when his COBRA ends, that would trigger a special enrollment period for you then to go into the marketplace at that point.
Okay, so let's say it ends February 8th. So at that point, okay.
Well, I would start in January.
Okay.
To look and make sure, because you don't want to have any gaps in coverage. But what
Right.
you can do in January is you can start to look at what your options are, pick a plan, fill out any paperwork, so that it wouldn't create any sorts of gaps in coverage.
Okay.
So that, and you might even end up with like an 8-day overlap.
Okay. All right. Thank you for that information.
You're very welcome.
Okay, it looks like we have one in the chat box. It says, for states that did not expand Medicaid, what insurance options are available for unemployed adults who are not deemed disabled? Are they eligible for an ACA plan with no income?
So if they didn't expand Medicaid, then they would be eligible to purchase a plan in the marketplace. The challenge is, without income, how are they going to pay for it? And that's what I was talking about with respect to the gap in those states, in that the premium tax credit doesn't go down to 100% of the federal poverty level. So in order to get a tax credit, somebody has to have over 138%. And so that's the really legitimate challenge that people are facing. And so they're often ending up either staying uninsured, or sometimes they can get jobs with insurance, but it's not a great situation, for lack of a better phrase.
Okay. All right. Hopefully that answered their question. I see another one from Carolyn. She says that the marketplace healthcare.gov has a new alert this year as part of the sign-up process that you are not eligible for a premium subsidy in the year in which you will become eligible for Medicare. It also alerts you that your plan will be canceled once Medicare starts. So what's with that, and is that correct?
Yeah, so the way that the ACA set this up was that if somebody was eligible for Medicare, Medicare was their option. If somebody's eligible for Medicaid, Medicaid's their option. And the marketplace with the financial assistance is supposed to bridge the gap between those. So that is, in fact, that has always been the case. It's interesting. I didn't know there was an alert to say that. Maybe that has to do with your particular age. But again, the hope is that you be covered under Medicare at that point. And so what would happen is your marketplace plan would end and Medicare would start.
Okay.
I hope that answered the question.
It's hard with these chat box ones, but I'm sure we'll hear. You guys can always follow up if you do have any extra questions on top of what's been answered by Monica. We are getting to the top of the hour, but I just wanted to throw one more in. This one's from Gail. I lost my job and I'm on COBRA. I can stay on until the end of June, but it is pricey. Can I look at Marketplace anytime between now and the end of June and perhaps change before then?
Yes and no, but not any time before June. So if you're on COBRA, if you've chosen COBRA, you can only make different choices during open enrollment or when your COBRA ends, which would be a special enrollment. So if you think that you don't want to stay on COBRA until June, you need to actually make that choice now during this open enrollment period. You have to keep COBRA through until January 1 because that's when your new marketplace plan would start, but then you wouldn't have it for the next 6 months. So you need to make that decision sooner rather than later and decide before December 15th what your plan is.
Good to know. We'll take one more question. This one comes from Lisa. Lisa asked, to find out what costs are covered in a clinical trial monitoring, do I have to check each insurance policy, or are the visit costs standard under the ACA? I anticipate monthly appointments for 6 months.
So what I would suggest is that you talk with the clinical trial and ask them to let you know what routine care would be for your condition. And then that would help inform the answer to that question. Because if monthly visits would be routine care if you were not in the clinical trial, then insurance companies still have to cover that. But if routine care for your particular condition would be every other month, then the insurance company still has to cover, the 6 that they would have if you weren't in the clinical trial, but then you're going to have to figure out how you're going to cover the other 6, assuming you do the monthly for a year. So I would definitely recommend talking with the clinical trial because they should have the information about what is considered routine care for your condition and what the clinical trial is asking above and beyond that routine care. And that should help you figure it out.
Okay, great. And just to reiterate, so open enrollment began on November 1st and it ends December 15th. Is that correct?
In most states.
Okay.
Yep. So some states like California, for example, runs their own marketplace, and then so people have longer in those states to make decisions. But in most states that have a federally run marketplace, December 15th is the last day to make choices. So if you don't know where your state is, take a look at our chart of state laws, and you'll see the states with state-run marketplaces.
Here, and then I just put that back up just so everybody has that for reference. So it is a little bit past our ending time, so I do want to just cut it here. Thank you so much, Monica. I know that this was a really valuable webinar and very timely, so I hope you all felt the same. We really appreciate your feedback, so we'll be circulating the online evaluation, and we really would appreciate if you could fill it out so we can just continue to develop this program to meet your needs. Again, if we were unable to get to you during the call, please feel free to email us your questions at cancerandcareers@cew.org, and we'll be sure to get the answers for you. Once again, requirements for the CEUs can be found on this slide. And again, thank you so much, Monica, for explaining in such understandable terms a topic that's so complex. And thank you all for attending tonight. Have a great rest of your evening.